Cardon Children's Medical Center, providing comprehensive pediatric care for Arizona's families.
I'm Nathan Page. I am a pediatric otolaryngologist. I'm with Arizona Otolaryngology Consultants, and I work primarily out of Banner, Cardon Children's Medical Center. The primary symptoms of an ear infection are fever, irritability, and in an older kid, ear pain. Younger children sometimes pull on their ears. Unfortunately, those are also the most common symptoms of any kind of cold or upper respiratory infection. So there's no way to know at home, although some parents, after their kids have several infections, get a feel for the pattern that they seem to have. But really the only answer is to have a diagnosis made by a doctor who can look in at the ear and see what's going on. Let's look over here. See what you got in here. What do you think's in here?
Jellyfish.
Jellyfish! The gold standard for diagnosis for ear infections is otoscopy, so that's looking with the little otoscope. Sometimes they have to make a difficult call about whether an ear infection is truly the situation. And the younger the child, the more cautious we are in terms of treating those aggressively. This is a cutaway view where this is the outside of the ear, the part you can see. This is the ear canal. This is the part that gets infected in swimmer's ear, or otitis externa, an external ear infection. So I should clarify that that's a completely different problem. Swimmer's ear happens out here in the ear canal. When the canal itself gets irritated, it's usually very painful. There's usually drainage. Here's the eardrum, and beyond the eardrum is this space that's called the middle ear. So infection of this area, or inflammation in this area, is called otitis media. And this is the problem we've been talking about today, the most common ear infections in children. So the eustachian tube has cartilage over part of its length and has muscle that surrounds much of it as well. These muscles come down and they insert on the soft palate. In small children, this is actually at a much different angle. It's much flatter so that gravity isn't to your advantage, and it's much smaller and flimsier. The cartilage hasn't developed the strength yet, and so it's much easier to collapse the eustachian tube in small children. When that pressure is not equalized, the symptoms come from the pressure and the movements of the eardrum. So negative pressure in the middle ear from chronic obstruction of this tube leads to fluid, which can lead to infection. The primary treatment that's still recommended for an acute ear infection is amoxicillin, and has been for a long time. And unless there's an allergy to amoxicillin or the child has been treated, say, within the last month with amoxicillin, we continue to treat with that as the basic drug. We are not concerned about antibiotic resistance on an individual patient level. So we're not worried about one child in particular becoming resistant. We're worried about the bacteria that are being passed around in the population becoming resistant. Most commonly we see children who do respond to antibiotics but need to be treated repeatedly. So after a certain number, there's no magic number of infections, but after a period of time with recurrent treatment of these infections, that they refer to us for further assessment and management. One of the other simple treatments that I'll just add in is saline irrigation of the nose. So even for infants, this can help thin mucus secretions and help clean out some of the junk. Tubes are mostly used for children who have recurrent infections that go beyond a certain level. So recommendations that have been given in the past are numbers like 4 infections in a year or 3 infections in 6 months. Some use a little bit stricter criteria and say 6 infections in a year or 4 infections in 6 months. Those numbers do have to be taken a little bit with a grain of salt. You have to consider things like the age of the child, the severity of the symptoms that go with the infections, the family history, and the time of year. So when we put ear tubes in, we make a small incision in the eardrum itself and place a tube across there to keep that hole open. What that does is allow direct pressure equalization across the eardrum so that the air and the fluid can move across that without any difficulty. Ear tubes don't fix any underlying problem. What they do is they allow for symptom relief and decrease the number of infections while we wait for the immune systems to develop and for the kids to grow and get out of their highest risk age. So if you can get a child through a winter, then they have a whole summer that they can be healthy while they wait for the next winter to come along. And the hope is that by the time you reach the next winter, they may have grown out of it and not have problems anymore. Younger children are at risk. Children in daycare are at risk. Children, we know that breastfeeding is helpful over bottle feeding in terms of decreasing the risk of ear infections. Tobacco smoke exposure is a risk. And so some of those are manipulable. Some are not. So a family history of ear infections, race, Native Americans typically have higher rates of ear infections, and exposure to your own siblings at home, those are not manipulable factors and put you at risk. And those are some of the things that we do consider when we're thinking about how aggressively to treat a kid. Allergy is another significant issue. Children with environmental or food allergies are at higher risk because of the swelling in the nose and the back of the throat and the causes of eustachian tube dysfunction. Large adenoids, which can be related to allergy or other infections, can both seed the ears with infection as well as just by their size block the eustachian tubes. So all of those things need to be assessed in that picture. There, in particular, in the food allergy situation, kids who are dairy intolerant can have chronic nasal and ear problems. It's not clear whether this is an allergy, but some parents, particularly those who have a family history of dairy intolerance, have taken their children off dairy and seen significant improvements in their nasal and ear problems. When they come from a family where the siblings had ear tubes and the parents had ear tubes, I say, you know, this is inevitable. When the kid starts having ear infections, you know, we might as well intervene early as late because it sounds like we're going to have to do something. My daughter had only had one, I think, ever. She did very well. My son had actually quite a number when he was about 18 months. Between about a year and 2 years, he had his peak of ear infections. At the time, I was an ENT resident, and so I got advice from the surgeons that I worked with, and we kind of watched him symptomatically as well. He fit the profile of a lot of kids. He was mostly okay during the day, but at night, screaming, fevers, irritable, not taking bottles like he would. And the next morning, he would seem okay again, you know, for much of the day. And some parents do find that distraction works great. The kids have something to play with, they feel a lot better, everyone's okay. Nights can be really hard with kids with ear infections. The more severe it's affecting the child and the family, the more aggressive we have to be in terms of planning an intervention. As I went through my training, I realized that I was happiest when I was at the Children's Hospital, that I liked working with the kids, I liked working with the families, and I felt like that's where I was best. I thought that my skills were best there, that I was happier there, and that I felt like that's where I would make the biggest impact.